Mission and margin is the business of healthcare. I'm your host, Matthew Hanis, founder and executive producer of the business of healthcare. Today we speak with physician executive Dr. Dale Owen, practicing cardiologist and chief executive officer of the newly formed Tryon Medical Partners. Owen and his 88 partners recently separated from Atrium Health and reformed as an independent physician practice.
I think we can have a significant impact here as independent physicians. The issue around the United States is that from an insurance standpoint, the Southeast is still a hub of fee-for-service. And Charlotte itself is a bastion for fee-for-service in the nation. And as a result, when you're driving volume and you're in a fee-for-service market, you're going to drive up healthcare costs. And it's not necessarily when you're only spending 15 minutes with the patient and half of it is on the computer, you really don't have the time either to be able to take care of the patient properly. So both of those things lead to high costs, less reward in the taking care of the patient and the outcome data. So how do you change that? Well, you need to be able to have independent physicians to contract with the payers themselves and then move rapidly into a value-based platform.
In his full Business of Healthcare interview, which follows and is available at bohseries.com, Owen explains why he and his partners made this recent change, why plans to take on population health risk is critical to physician engagement, and the challenge of standing up a 75,000 patient practice in weeks. Tryon, originally founded in 1936, rebranded as Mecklenburg Medical Group in 1972, and then joined Atrium Health in 1993. The return to independent practice occurred on September 5, 2018. Dr. Dale Owen serves both as Chief Executive Officer and practicing cardiologist. He holds an undergraduate degree from UNC Chapel Hill, medical school degree from Wake Forest Bowman Gray. His internal medicine clinical practice began in 1986, followed by becoming a cardiologist. Dr. Owen is board certified in internal medicine, cardiovascular disease, and nuclear cardiology. Our thanks to the North Carolina chapter of the Medical Group Management Association and Mako Medical Laboratories for making this interview possible. By watching or listening to the full interview, you may earn up to 0.5 continuing education credits. Dale Owen, thank you so much for joining the Business of Healthcare today. You've had a pretty big year. Tell me about what's happened.
Well, I'm CEO of Tryon Medical Partners, and we are a newly formed multi-specialty group that has started practice as of 9/5/18, and we're opening 8 offices and have 88 physicians, 63 internists, and 25 subspecialists, and we're starting our independent practice here in Charlotte and the surrounding county.
The journey there, a big part of that journey was about physicians and how physicians feel about their service to patients. Tell me a little bit about that.
Well, I think that we were feeling that we really weren't practicing the type of medicine that we entered the medical practice for to begin with. And I think it's a special bond that physicians and patients have, and we take it pretty seriously that we want to do the right thing for the patient at the right time. So that's what we're really all about. It's been a great transition for us. We were previously owned by a hospital system, and now we're an independent practice. And we feel like we're in much more control of how we can practice medicine, spend the time with the patients, help them with the multiple things that they have going on that are bothering them.
So in this journey, you spent a lot of nights and weekends in your colleagues' living rooms and having that conversation. What were those conversations like?
Well, I felt like that this was really going to be about knowledge, numbers, and perseverance and our ability to pursue this endeavor. So I went around the country and talked to lots of CEOs of different organizations, and then came back to our group and on an individual basis went around to each of the physicians, and initially about the first 65 or so, to make sure that we were all of like mind. And that I found very inspiring. They truly understood exactly what we were trying to accomplish and were really all in from the beginning, which I found surprising, especially the varying age groups within the physician practice.
Tell me more about that, like a conversation that you had with a young colleague and an older colleague. What were those like?
Well, the older colleagues are clearly close to retirement, but they had also been in the initial purchase of our group in 1993, and so they were very interested in getting back to independent practice and felt like that they were hang on for another 3 to 5 years instead of retiring in 1 to 2 years. I found the most inspiring part was the younger physicians, literally those who had just been starting practice for less than 6 months. And they understood something that I thought was very mature for their situation, which was now's the time in their life to take an opportunity to do something great. They have the rest of their career, if things didn't work out, to make up for that.
They're carrying debt from their medical school. They're carrying probably a family. That's a lot of risk for a young emerging physician.
It really is. When I graduated from medical school, and we won't talk about when that was, the debt was significant, but it wasn't overwhelming. Now some of these physicians literally told me that they have as much as $250,000 in debt coming out of college, medical school, and as one put it, it's like having a house on your shoulders and you don't even have a place to live yet. So I think that part to me is very inspiring. Plus then you add on top of that the financial input that they put into this process on top of it to secure the buildings and the infrastructure and so forth in our new practice.
What is the patient experience like in this go-forward practice?
Well, I think that to understand what we're going to do in the future, we have to understand what we did in the past.
Yeah.
So in the past, it was more about volume, numbers seen, referrals, admissions, things of this nature, and that's really not what medicine is about. Medicine is really about taking care of people and doing the right thing, and we felt like we needed more time to be able to do those things from a primary care standpoint. And specifically, internal medicine is what we're founded on, which is the group of physicians who train specifically in adult inpatient and outpatient medicine. And we're practicing as an outpatient facility, and our internists, there are 63 of them as a matter of fact, will be able to handle the primary care portion of things, and hopefully by spending more time with those patients, they will be able to handle the numerous medical issues that they have.
So somewhere in the order of 75,000 upwards of possibly 100,000 patients would theoretically be in your panel. Is that?
Well, upon separation from our previous employer, there was a joint letter sent out to 115,000 patients that we had seen over the previous 2 years. We think that there's probably more than that between 2 and 5 years. But from that 115,000 patients that were sent letters, the response has been overwhelming. We've been open since 9/5, and in that period of time to date, we have approximately 70,000 patients who have already enlisted with us.
Wow. Well, I think one of the things you were telling me about is just the sheer complexity of standing up a call center to take those phone calls. Even that was a big undertaking.
Well, it is. At the very beginning, when you have that volume of patients that you might potentially see, we weren't sure exactly how many patients would call initially, but the phone calls were overwhelming to the point that on a daily basis, starting on 9/4, just before we opened, it was 3,500 to 4,000 calls per day. Yeah. Very difficult to be able to handle with the staff that we had hired. So I made a plea to the group and sent it out on our message board, and the next morning 47 physicians were sitting in chairs answering phone calls, and we handled the volume.
In other words, I as a patient would call, and it wasn't just a friendly voice answering the phone. It was possibly my own physician answering the phone.
It was the youngest doctors, it was the oldest doctors, it was the board of directors, it was the CEO, it was all of us. When
you think about that transition from volume to value, and the U.S. medical system, $3.6 trillion in 2017, It seems like there's only two ways to beat back the beast. It's either drive down unit cost or eliminate unnecessary units. How does what you're doing serve that purpose?
Well, I think that you have to understand that about 5% of the patients are costing about 50% of the healthcare spend. Don't quote me on the exact percentages, but it's something close to that. And we feel like that internal medicine is what's capable of handling those very complex patients. If we give them the time and the resources to do it, the healthcare spend will decrease. It's been backwards. We've been paying subspecialists primarily, and we've been underpaying primary care. That's in pediatrics, family practice, and internal medicine. Our model happens to be internal medicine. But I think if we give them the time, they'll be able to do what they do best. But we're going to have to pay them for it. So we can't just push volume like we've done in the past. Now we need to push quality, time. And that means we're going to have to invest more in primary care. By doing so, we help to eliminate the unnecessary spend and the referral process and admissions that aren't necessary, ER visits, et cetera, that are overwhelmingly expensive.
You do face a financial conundrum because the reality of how large employers and large payers and Medicare and Medicaid, virtually all those programs predominantly pay on units of work performed. And your proposition is we're going to do a better job with complex patients to reduce unnecessary units of work, which is what we all want for those patients, especially the patients themselves, but the economic incentives that you face are not aligned with that.
Well, I think that when we talk to insurance companies, now that we are no longer hospital owned, we direct contract with the insurance companies. They get it. They really do understand that this is the way it has to happen. The issue now is how are we going to increase the value and the remuneration for those RVUs for primary care?
So you have to find a way for the insurance company, who is equally aligned in interest as you are, to mutually agree that, hey, we're going to pay more for this primary care value of diagnostic and patient management, and not necessarily pay less for, but pay fewer of hospital admissions and acute procedures.
It will lead to that naturally.
Yeah.
I think the other issue here is, and what I think is another cohort that we need to be discussing things with, are employers. Yeah. We need to be direct contracting with employers. We might even consider direct contracting with individuals, but I think that there are multiple sites that an independent practice can engage. To the payers, all of the payers, to the employers, and to the potential patients as well.
As a Charlottean, one of the things that really intrigues me about what you're doing is the potential impact in our market. We are one of the most expensive healthcare markets in the country, spend per capita. Our outcomes measures as a region are not very good. The ratio of people with healthcare coverage, percentage of opioid addiction, major measures of population health like infant mortality and obesity and diabetics. We've got a pretty big challenge in our market, and I feel like what you're doing could be a game changer to that. Does that resonate with you?
Well, it really does. And as a native Charlottean, I'm hoping that we're going to be as successful as I think we will be. I think we can have a significant impact here as independent physicians. The issue around the United States is that from an insurance standpoint, the Southeast is still a hub of fee-for-service. And Charlotte itself is a bastion for fee-for-service in the nation. And as a result, when you're driving volume and you're in a fee-for-service market, you're going to drive up healthcare costs. And it's not necessarily when you're only spending 15 minutes with the patient and half of it is on the computer, you really don't have the time either to be able to take care of the patient properly. So both of those things lead to high costs, less reward in the taking care of the patient and the outcome data. So how do you change that? Well, you need to be able to have independent physicians to contract with the payers themselves and then move rapidly into a value-based platform.
Imagine, if you will, we had the CEOs of the larger employers in town, B of A, Wells Fargo, Mecklenburg County. If you had that as an audience, what would be a concrete example of how you could impact their total medical spend?
Well, that's interesting you mention it that way, because that's exactly the meeting I was in yesterday. And discussing those very same things. So we have to get them to understand that we have to invest in primary care first. That can't be at the end. We can't say, let's drive a lot more patients into primary care. You have to understand that they've got to be appropriately remunerated, compensated, let them have the time that they need so that it's not about volume. We think that as independent physicians, and we already know this part, going directly to the payers, we can shave approximately 15% off the top right there. If we go directly to the employer, there's as much as 25 to 30 to 35% savings available to the employer at that level.
Is that 35% savings meaning a primary care level 4 visit is billed at $153, you can bill it at a lower rate? Or is it the primary care billing may actually go up, but the downstream cardiology visit, the downstream...
Precisely. You're exactly right. We invest in primary care so that primary care isn't forced from a volume standpoint to send patients out, refer more, and they can also handle a lot of the patients that are calling in for acute visits, and we can see them as well instead of sending them to high-priced and expensive emergency rooms, urgent cares, and so forth.
Behavioral health integration is a significant opportunity in impacting primary care. The idea of embedding behavioral capabilities, diagnosing and treating addiction, mental health, behavioral disorders. Do you have a vision of integrating behavioral health into the practice?
Not just behavioral health, there are other things that we need to integrate as well, but speaking just to behavioral health, there's no question. It's a huge issue. We have to deal with it. It's not been dealt with very efficiently or effectively in the past, but that is number one on our radar to bring into our group and to align with other groups that provide the same type of behavioral care that we can solve this problem.
What changes in the physician experience?
Well, right now the adrenaline level of all the physicians is peaked out. We have been so excited and invigorated in starting this practice. I've never seen a group of physicians come together of like mind, lock arms, and get going. We've done a great job with it. We're standing up 8 new offices and an administrative office as well. That's over 160,000 square feet of office space. We had 4 months to do it.
Wow.
Now, we had to be pretty prepared beforehand, and when we had our settlement agreement and so forth on early July, we knew that we had to have everything ready and opened up by essentially Thanksgiving.
So one of the big issues we face in this country is not only a shortage of physicians, but physician burnout. And talk a little bit about that.
It's palpable. And I used to be an internist with our group, went back and did cardiology training, and I did that not just because I loved cardiology, but I really didn't like what I was having to do in internal medicine. The number of charts we were taking home, going to bed at midnight, and you weren't even on call, and you're up and still seeing patients at 7 a.m. the next day. It's no family life and so forth. Physicians do something that's really unique to human beings, and that is that they decide to go and train for multiple years to help other people. That is something that's really embedded within them. That's in their nature. And to not have the ability to do that and enjoy it, and the time that you can spend with the patients, and then have to spend all the time afterwards, became a huge burden. And physician burnout has been significant for primary care for a long period of time now, but it has really reached a peak at this point.
Have you already seen the moment where you're seeing a decrease in physician burnout?
Absolutely. One of the models that we have is that although we initially stand this practice up in the fee-for-service model because that's what's prevalent here right now, we're going to move rapidly into the value-based medicine. Just that understanding, and that we're going to invest in primary care, and that there is light at this end of the tunnel, That's what has them so invigorated. And they realize that even though they're still in this certain mode right this minute, it's going to change really soon.
So you stood up a large-scale practice in a very short period of time. You built a dream team. And I find two things really interesting. Well, talk about your dream team and talk about how you know your folks on the dream team.
I went, as I mentioned at the beginning, all over the country for a couple of months to try and figure out what we needed. And then once we felt like we had the knowledge and we had the numbers, now we had to have the ability to stand up the group. Well, my wife and I, my wife's a Moorhead scholar, and she and I did some investigation on what kind of legal staff we needed, what kind of staff we needed to help stand up the group and so forth. I went to a personal friend of mine who'd had 35 years in the insurance business. He was incredibly engaged in all of this. I also touched one of another friend of mine from high school who was the Duke Energy PR director.
This is Tom Williams. Yep.
And he has mentored me and helped me so much in the PR standpoint. The gentleman I spoke of earlier is Gaston Gage. And we've also had a high-level financier, Mr. Thole Gill, involved, who was involved in derivatives and so forth in the banking industry in the past. On top of that, we then hired two gentlemen from Accenture who came out of retirement. That's amazing that Gaston, Thole, all of these other people, everybody's retired but me, but they're all the same age, so they all come out of retirement to help us. Yeah. That's been amazing.
You've built a template now. When you began your journey a year ago or so, there was no template out there, but you've now created a template of how a large physician group could develop as an independent practice. What do you intend to do with that template?
Stand up our group first.
Okay.
Make sure we're stable, but in the same breath, in a parallel track, be ready to take it outside of Mecklenburg County. Within Mecklenburg County, there's tremendous interest in joining us helping other groups of physicians and so forth. We can't really talk about those things at this point.
Sure.
But there's also significant interest outside of the state and outside of this county. Within North Carolina, tremendous interest. Outside of the state, also tremendous interest. This is being followed nationally. And several insurance companies told me personally that we are the worst kept secret in the nation. I didn't know that or realize it, but once we were separated legally, then all the different newspaper agencies and TV stations and so forth and national agencies have come to us and want to understand our story so that we can take it out and publish it, obviously, but we are going to take this out ourselves and use our template to help others and show others the way to do this.
Yeah, I can imagine you got a lot of supporters and champions. You probably got a lot of people trying to sell stuff to you, and you probably got a lot of people who are well-wishers. It's got to be pretty stimulating.
Well, I'll give you a great example. In our Pineville office, I went out into the lobby and I was shaking hands with everyone and just telling them thank you for coming in and so forth.
These are patients that
These
happen
are patients, even some staff, but primarily patients and their families and so forth. And literally one person said, we can't believe that the doctors have put their professional careers on the line for us. Yeah. And then everybody started to cheer and clap. So we understand that what we need to do, because we're physicians and we care about patients, we need to do this. It's really our job. We can't expect others to do this for us. There are two groups of people who really care the most about patients and physicians. And together we need to reinvigorate that physician-patient relationship. And I think that those patients that I just mentioned, they see it, they understand it, and they can feel it.
So you've created this template of how to stand up a large and complex practice in a very short period of time. What comes next?
Well, I think that we have to grow. We have to stabilize ourselves locally first, and then we need to grow. And it needs to leave this county into other portions of the state, even outside the state. But probably most importantly, we need to link up with the other independent groups, and we all need to foster the same vision and be able to bring others with us. I think when we're so focused on our own survival, we forget about what's important about linking with the other groups that are independent as well to create a national network, which is what I would like to see the most.
So I think of Wilmington Health, I think of Wake Physicians, I think of, I'm forgetting the name of the practice in New Bern, but these independent physician practices that are of size and scale in their region. Your vision is perhaps make a super practice?
I think that we need to get heavily involved with them. I don't think that we have to form one practice because I think each culture is unique and important, and each venue and their market is probably different. But I think we need to teach each other about what all the obstacles are, how to combat them. Kelsey-Seybold in Houston, Texas is another one. A group in Cayuga Falls, Ohio is another example. And you mentioned Wilmington Health, and that's top of my list.
One of the things that I would be interested in would be the idea that while each of those practices operates in their own cultural reality, which is unique, and you could break a lot of things by disrupting that, the delivery of care to a human body, the human body is pretty uniform from place to place. The measures of quality are pretty uniform, and the ability to contract with large employers on a national basis in perhaps a clinically integrated network model or something like that, there's this opportunity where as a community of independent practices, you could remain independent and unique to the culture, but combine forces for the purpose of measuring quality, having good data infrastructure, and contracting in a value-based model.
I couldn't have said it any better. I think that's exactly right. My vision from the very beginning has been to stand up our practice and then integrate and network with all the others that are of like mind and share data and help each other grow and foster their own culture and so forth and be successful so that others are inspired to do exactly what we're doing. Make it not look as scary as people think it is. It's really not. Physicians are a lot more in charge than they think. They just need to bind together to have the force and capability to do this.
Is there a cultural reason, a characteristic of training, the nature of who is drawn to medicine? Is there something about that that leads to an individual who tends to gravitate to independent action, and there's a river to cross around collaboration and working together?
Well, I think that physicians, they go into medicine to help people, and they put their lives into that. I mean, that becomes their purpose. And it makes it difficult to bring in all of the other understandings of what goes on in a medical practice. They're so concentrated on getting through residency and then becoming a great physician and seeing patients appropriately and so forth, that all the other aspects of medicine, the business of medicine, is not really understood as well by physicians as it should be. And it's never taught at the medical school level either.
There's a whole other set of stakeholders in addition to other practices. There's technology stakeholders, EMR vendors, there's law firms. Talk a little bit about that part of the world and how those stakeholders fit into your vision.
Well, I have to give kudos to the legal teams that helped us. We entertained national search to look for the people that could help us. We used one organization out of Philadelphia and Baltimore, Saul Ewing, and we used another organization, Nelson Mullins, out of Raleigh, and particularly Noah Huffstetler and his team with Mark Stafford and several others that helped us understand what our contracts were about, where the holes were in them, and gave us a plan and really helped to organize our thought process about what we needed to do. They're masters at this and would highly recommend that others seek them out to solve their issues as well.
And what about partners in the supply chain? We've got Mako Medical here, the laboratories that concentrate on independent physician practices. There's all of the supply chain like immunization and flu shots. How does that supply chain fit into your thinking?
As the CEO, that's not the part that I'm dealing with most,
Yep.
but our staff is highly invigorated in that and finding the right partners that from a cost containment, from an ability to supply and do so reliably becomes critically important to us, because they're the ones that supply what we need to supply to the patient. If we can't have them supply it reliably, we can't deliver it reliably either. So those are the types of partners we're looking for. And we're looking to partner with people as well. We'd love to see partnerships with suppliers in this field.
Is there a transfer of risk opportunity? Is there, as you step into the world of risk-bearing contracts with employers and payers, is there an opportunity for the supply chain to partner with you in that risk?
There are opportunities for independent physicians to partner with just about everybody, but the answer to that is absolutely yes.
Dale, Owen, thank you so much for joining the business of healthcare today, and thank you for the undertaking. You're taking on an incredibly bold agenda, and I'm so excited to see how this develops over the next 3 to 5 years.
Thank you very much. Appreciate your time.
By watching or listening to the full interview, you may earn up to 0.5 continuing education credits. To watch, listen, or read other BOH interviews, visit bohseries.com or search Business of Healthcare in our red logo wherever you listen to podcasts.